Good afternoon. Good afternoon. Beautiful day, sunshine, no snow. Thank you all for coming. What a beautiful day it is. I would like to welcome to the podium our Vice President for Academic Affairs and Dean of the Faculty, Dr. Wolfgang Nader, to say a few welcome remarks. Wolfgang?
Thank you. Thank you. Well, good afternoon. It is a great pleasure to welcome you, Dr. Gerald Eisenberg, Dr. Lakshmi Acheson, dear colleagues, students, and other members of the Chestnut Hill community to today's lecture. As you know, the college has sponsored an annual Distinguished Biomedical Lecture for a number of years now, and today's lecture by Professor Eisenberg will be the 22nd of the series. Ably overseen all these years by Dr. Acheson, the series is one of the most lustrous events in the college's academic calendar. For 22 years now, scientists of vision and achievement have spoken to our community, met with students and faculty, and brought their passion for learning and discovery to Chestnut Hill College. Our guest speakers have included elected members of the National Academy of Sciences, Nobel laureates, endowed professors, department chairs, and research institute directors at some of the nation's most renowned research universities and facilities. I am very grateful to Professor Eisenberg for accepting our invitation to continue this tradition. In a moment, I shall be turning the mic over to Dr. Acheson, who will introduce Professor Eisenberg's exceptional history of distinguished achievement for you. Before I do, however, I want to introduce our lecture series organizer. Dr. Acheson has been a faculty member at Chestnut Hill since 1992 and full professor of biology since 2002, a department she has also served as chair. Professor Acheson has taught widely in the areas of cell and molecular biology, as well as on science and technology, bioethics in medicine, and plant morphology. She is a recipient of the Lindback Award for Distinguished Teaching and has received recognition from the Human Anatomy and Physiological Society and the American Association for Cancer Research. She has been awarded a patent by the United States Patent and Trademark Office for the blood cell model she developed. Perhaps we'll discuss that later on. And recently, she was able to celebrate the 3rd edition of her book on cancer biology basics and preventive strategies on 8 cancers that can affect high school and college-age students. Dear students, if you have not seen this book, please make a point to do so. But your smiles tell me many of you have seen this book already. Please join me in welcoming Dr. Acheson to the podium and the wonderful introduction she will be offering of our distinguished speaker.
Thank you, Wolfgang, for the beautiful introduction. I don't deserve all that. I greatly appreciate that. 2 quick announcements. During fall, we have the upcoming speaker is Dr. Stephen Hunger, who is the newly appointed Chief of Pediatric Oncology, will be our guest, and he will talk about childhood leukemia. I am delighted to say that our 2016 speaker will be the Nobel laureate, Dr. Harold Zurhuisen, and his work is mainly on his linking human papilloma virus to cervical cancer. Especially, he isolated the strains HPV 16 and 18 and linked to cervical cancer, and that led to the discovery of a famous vaccine, Gardasil, which is used by millions of women and also by men. So we are going to hear him March 21st, 2016, as our keynote speaker in of the 23rd Annual Biomedical Series. He will join the rank of the 2 other Nobel laureates, Dr. Stanley Prusiner from the 10th anniversary and Dr. Michael Brown from 20th anniversary. And Dr. Gerald Eisenberg will join the rank of all the distinguished speakers that we have had for the last 22 years, and who have been very generous and gracious to come to this college and spend their entire afternoon with us. And it is pretty humbling for me, and they have come with such humility. Dr. Eisenberg was introduced to me by our 19th annual biomedical speaker, who you all know, that Dr. Charles J. Yeo, famously known as a pancreatic cancer surgeon from Thomas Jefferson University. When I called Dr. Yeo, he said readily, he gave me Dr. Eisenberg's name, and here he is, and thank you for coming. Who is Dr. Eisenberg? Dr. Eisenberg, as you know, Philadelphia Magazine's top doctor for the last consecutive 4 years. And he is a colorectal cancer surgeon and a leading expert in colorectal surgery, and among many other distinguished credentials he has got, which I'm going to be mentioning in a few minutes. Why do we have to talk about colon cancer? Colon cancer is the third leading cause of death in the United States. Globally speaking, there are more than 1 million people get this cancer. Statistically speaking, in the United States, 130,000 people get it. This is 2013 statistics. 50,000 people die each year. This is a staggering number of 137 a day of colon cancer. So that is really staggering. So, did you know that colon cancer March is the colon cancer month? And I want to set the stage for the young students who are here. Colon is also called large intestine. What can go wrong with this powerful organ? Who better can tell us about this other than our expert himself, Dr. Eisenberg? Dr. Eisenberg is a top physician in the country and has spent his entire life in colorectal cancer studies. And he received his bachelor's degree from Brandeis University in biology with cum laude, and a medical degree from Mount Sinai School of Medicine. He did his internship and residency at the Department of Surgery, Lenox Hill Hospital, New York, fellowship in colorectal surgery at Thomas Jefferson University. He started as an instructor in surgery in New York Medical College and in Jefferson Medical College and at the University of School of Penn Medicine. He then moved on to California, Irvine, as a young assistant professor and clinical professor of surgery. Moving fast forward into 1993, Dr. Eisenberg moved back to Jefferson and soon appointed as a full professor of surgery. Currently, he is the program director for colorectal fellowship program. He is board certified in American Board of Surgery and American Board of Colorectal Surgery, and licensure of Pennsylvania and New Jersey. Dr. Eisenberg has received numerous awards, honors, recognitions. There is a huge list. Just to mention a few, he is an elected member of AOA, the prestigious Alpha Omega Alpha Honor Society, and elected to Jefferson Academy of Distinguished Education called JADE. He is the recipient of Dean's Citation for significant contribution to the advancement of education, Dean's Award for Excellence in Faculty Mentoring at JMC, and he has a huge list of membership in professional and scientific organizations. He is a member of academic community at Thomas Jefferson University. He has major teaching and clinical responsibilities at Thomas Jefferson and affiliated hospitals. He has made significant educational contributions like problem-based learning, introduction to clinical medicine, advanced basic science, and scientific foundation for clinical medicine, and many more. He has presented hundreds of papers and has huge list of publications, and more than 200 to his credit. Dr. Eisenberg has numerous research publications in peer-reviewed journals, reviews, abstracts, book chapters, journals, etc. And he also has electronic peer-reviewed publications. As medical director, he has scientific electronic links on many case studies along the length of the gastrointestinal tract. In addition to all this, he has been a principal investigator for federal grants like NIH and many other sources. His research work is extraordinary in colorectal cancers. Honestly, I could not justify all that is listed in his excellent dossier, forgive me. Dr. Eisenberg has been in practice for over 30 years. He is board certified in colon surgery Excellence in Teaching Award from Jefferson School of Medicine. He was appointed as Vice President of the American Society of Colon and Rectal Surgeons, and many more distinguished titles, some of which are mentioned here. Dr. Eisenberg is a true role model for all the colleagues and to the new generation of medical students. Dr. Eisenberg, what can I say? What an honor to have you with us today. Amidst your extraordinary busy schedule, you made time to come here and hang out with me for last 7 hours today, I am deeply humbled. I try to look very busy in this college after dissecting a dead cat in the anatomy lab, and I look exhausted. It is with deep gratitude. I want to thank you on behalf of our president, Dr. Sister Carol Jean Vale, Dr. Wolfgang Nader, Vice President for Academic Affairs and Dean of the Faculty, and Dr. Cecilia Kavanagh, Dean of the Undergraduate Studies, and the entire college community, and my dear colleagues, Biology Department, Joe, Ken, Bob, Lisa, Barb, and Elias. They are with me all the time. Without their support, I cannot run this program. Dr. Eisenberg will speak today on thinking out of the box and into the colon, a catchy title. Simply looking into the tunnel by an expert. When they don't see any tumor or obstruction, you know what? They have seen a light at the end of the tunnel. That's what patients want to know. Ladies and gentlemen, it is with distinct honor and privilege I introduce to you the Professor of Surgery and 22nd Annual Distinguished Biomedical Series, Lecture Series speaker. Would you please put your hand together to welcome Dr. Gerald Eisenberg.
Wow. Is that me? I don't know how I did all that. It's incredible when you hear it. It's certainly a pleasure to be here, and you've shown me such wonderful hospitality, I might not leave. So thank you for the invitation, and it's really great to be here. So greetings to you from Jefferson, not so far away. This is old Jefferson from many years ago, and this is newer Jefferson. This is looking into our plaza and our newer, really state-of-the-art teaching building, and the library right here. And right down here is a statue of Samuel Gross, who's a professor of surgery from many, many years ago, and really one of the fathers of American surgery. So we're privileged to be at an institution that treasures the field of surgery. So as you've heard, I wear many hats, and I don't know how I wear them all, but I wanted to just give you a little sense of some of the things that I do. Most of the time, during the daytime, I take care of patients with colorectal problems. That takes up most of the day. Somehow in between, I squeeze in teaching medical students, surgical residents, and the fellow. We have a fellow each year to train them to be a colorectal surgeon. Along with that, I have responsibilities to the medical school because I'm chairman of the curriculum committee, something that I've been interested in for many years. And I think because I was on the committee for so long, they felt bad for me and just made me the chairman. But we've seen a lot of changes in medical education, and we're actually in the process of revamping our entire curriculum. That will start in 2016. And it's very interesting and exciting to bring new concepts of education to teaching medical students. So I do that, and I'm chairman of the operating room committee, so that's the hospital side of what I do to try to keep the surgeons kind of all in line and thinking the same way, which is pretty tough. And then the other side of me is the side, the family side, that I was talking to your wonderful students about. How do you balance things in life? And it's hard to do, But I do have one recommendation to everyone, because I have two wonderful little granddaughters that you'll see later on. I recommend having grandchildren as soon as you can, because there's nothing better than that, and that's what keeps me going. So here's my disclaimer. I have nothing to declare. No one has supported me to come here, or conflicts of interest. Some of the pictures that I'm going to show you are really cool for me, but maybe not so cool for you. And I apologize. I tried to keep them very tame, but you know, colorectal surgery has a lot of interesting pictures. And this is what we're going to try to do. I thought of the title before I thought of what I was going to say, so I'm not sorry I thought of the title, but I'm going to try to show you different things about kind of certain colorectal diseases. It's not all going to be cancer, I apologize. It's going to be different colorectal issues and show you how we think about those problems. And then I'm going to challenge the students especially to try to help us solve some of these problems as you move forward in your careers. So I thought we'd talk about constipation. And you know, normal bowel function, it's going to make a lot of you very happy, is anywhere from 3 times a day to every 3 days. So you can like have a sigh of relief, you know, you're not dying of colon cancer if you didn't go for 2 days. And so just keep that in mind. But if you are having problems, if you look at diet, that often is going to be the solution to the problem. And it's not only the food that you're eating, a lot has to do with what you're drinking. How much liquid are you drinking? Some people are good, they drink tons of water or juice, and other people are not. And so the way I figured out to kind of get them to drink more is you have to associate it with something that they do every day. And most people, except for maybe college students, have breakfast, lunch, and dinner. So I say you drink a glass of water with breakfast, lunch, and dinner, and then you will get enough liquid into your system to help the colon do what it needs to do, because the colon needs the water to allow then the stool to have enough liquid to come out. Medications. You can be on certain medications that are going to affect your bowel function. Some may constipate you, some may make you go to the bathroom more. Some may be things that you don't even think of. When I was in practice in California early in my career for a few years, I had a patient who had a lot of diarrhea. And we couldn't figure out why. And we're talking to him, you know, are you taking this? Are you doing this? You know, trying to figure it out. No, he's not taking any medication. So finally I said, well, are you taking anything? Well, you know, doc, I do have a lot of reflux. So I like take a Tums every hour. I said, you take a Tums every hour? Like, I asked, did you take any medication? Well, that's not a medication. So he stopped his Tums and he stopped going to the bathroom. So I love that. It's a simple solution, but you have to really tease out sometimes the problems, you know, that patients may have. Stress is an amazing thing that when it relates to the bowel, so both the small bowel and the colon. And so you've heard of irritable bowel syndrome. It used to be called spastic colitis. We don't call it that anymore. It's irritable bowel. That's not inflammatory bowel. This is irritable bowel. And that can cause constipation. It can also cause diarrhea, but I think more frequently people have constipation with crampy belly pain. And that is a diagnosis of exclusion. What do we mean by that? You have to rule everything else out before you can say that someone has IBS. Because there's no blood test or x-ray or something to show you that you have IBS. So you have to rule everything else out and then figure out that, okay, yes, this is what the person has. And I don't know if I said it already, but there are tons of nerve fibers from the brain to the gut that we haven't figured out yet. We really don't understand it. But you know, some people that are stressed out have a lot of belly symptoms. And so something you guys could do is figure out what all these fibers mean and how they control it. And you will help thousands, if not millions of people. Travel. I don't know what it is about travel, but you go somewhere, you change how you eat, you change how you drink, you change your schedule around. The food's different, and so frequently people get constipated after they travel, and they come to me and have some kind of problem related to that. So drink plenty of liquids, especially when you're away. And then other medical problems you have to think about. What comes to mind for me especially is thyroid function. Someone who is hypothyroid, thyroid's not working well, affects the gut, and they may get very constipated. So that's part of a workup. So, what do? Still can't go. More water, more fiber, more laxatives. Maybe start getting some lab work, see what's going on, depending upon the age of the patient, how long it's been bothering them. And then you may have to do something to look at the colon. Most commonly now, you would probably do a colonoscopy, which I showed a cartoon, not a real patient, but it's a tube that you put around the whole colon. And let's just review the anatomy, because we're going to be looking at this in more detail later. This is the rectum, the lowest part. You go around, this is the sigmoid colon, because it's an S shaped here. And then you go up the left colon or the descending colon. Now you're up under the ribs on the left side, and you cross over to the right side under the ribs, the transverse colon, and then you are here in the ascending or the right side of the colon. The appendix comes off right there. Now, just to put this in perspective, this as a colorectal surgeon, this is the way I think of first. Most people don't. You swallow something, it goes down the esophagus, into the stomach, into the duodenum, which is the beginning of the small intestine. You have about 10 feet of that, and that then empties into the colon here. Okay, so that's the anatomy there. So this is a scope. The end of the scope is a little video chip. It used to be a fiber optic tubes that we used, but now it's a video chip. And this is an actual picture inside the colon, normal looking colon. And this here is a blockage. This is a cancer in the colon blocking it off. Another test that you can do is a barium enema. This is what we used to do years ago. It's a lower GI X-ray. And this is, again, you can see kind of how I just showed you the anatomy, the whole colon. This is a normal looking colon. And how this is done is like a rubber or plastic type tube is actually put into the rectum, and you squirt a liquid barium around the colon, and the patient lays on their side, lays on their back, moves around. It kind of squishes the liquid barium around, and then you get a lot of pictures of the colon. Here you can see a blockage there, like the cancer that we saw on the picture. This is called an apple core. If you look closely, it kind of looks like if you ate an apple. It's the core of an apple. That's very typical for a cancer of the colon. So you can also look at the colon with something called virtual colonoscopy. You've probably seen it advertised. People want you to get this done. This is like a CAT scan colonoscopy. And what you do is you run someone through a CAT scanner a couple of times. They have to take a bowel preparation, a bowel prep, to get their colon cleaned out, just like for a colonoscopy or barium enema. But then they're run through a scanner, and you do it in two different positions. In case there's any stool left, it may shift it to another wall. And then you get this wonderful picture by a computer reconstituting it, because this CAT scanner is kind of taking slices through your body this way, and then a computer puts it all together, and pretty cool, shows you this picture of the colon. And that's an actual shot looking inside the colon. That's how it put it together. And you can see things like here. This is a tumor like we saw on the barium enema, the apple core, and also through the colonoscope. And that's pretty good shot. Now, someone wants to come up here in a few years and have won a Nobel Prize. It's not going to be me, but one of you got to find a way to tag the stool. What do I mean? If you can take a pill or a liquid without a prep, and it'll attach to the stool that sits in the colon, then you can CAT scan someone like this, and the computer will subtract the stool, so you'll just see colon, you'll see cancers or polyps, and the patient didn't have to take a PrEP. It's the PrEP that stops people from getting a colonoscopy. It's not the test itself. You're snoozing during the test. They don't want to go through that clean out process before. So if you can figure out a way where you don't have to clean out by tagging the stool, next Nobel Prize. Well, unfortunately, still constipated. You've tried everything. You're a gastroenterologist, the medical side of what I do. That doctor has said, I think this patient needs surgery. Well, okay, what part do I take out? Do I take out the left side? Do I take out the right side? Do I take out the whole colon? How do you know? So now we have to talk about two other types of constipation. There's something called slow transit constipation or colonic inertia, giving you a hint of what that's about, versus pelvic outlet problem. So colonic inertia is where the colon just isn't functioning right. It's not moving things around. It's kind of just quivering. So it doesn't push the stool from the right side around to the left side. So someone came up with a really neat idea. Let's have them swallow a capsule, and inside the capsule we'll have these little markers. And depending upon how these markers are displayed around the colon when you take an X-ray on day 1, day 3, and day 5 after they ingest it, that will tell you what kind of constipation they have. Now they can't be taking their laxatives because that would defeat the purpose. So they stop their laxatives, they take this pill, and you take the X-rays. If these little markers are distributed like they are here in this colon, all the way around, they have this slow transit constipation or colonic inertia. The whole colon's not working. If the markers were all down here in the left side, in the lower part of the colon, and not coming out, they have an outlet obstruction. Somewhere in the pelvis, it's not letting the stool come out. It's probably some kind of muscular problem or dysfunctional workings of the muscles in the pelvis. And that's why you would see it collecting here. Then we stay up late at night thinking of other things we can do to test people. And this apparatus is called defecography. And what we do for that is we actually put a pasty barium inside the rectum and then have the patient sit on a private commode and X-ray them as they're going to the bathroom. I know it sounds ridiculous, but it gives us a lot of information, and it shows us these muscles working or maybe working too well, and then they have pelvic outlet obstruction. Well, just imagine if someone had this pelvic outlet obstruction and I took out their whole colon, they're still going to have their problem. So I have to figure out, is it that the colon's not working or is it getting blocked here? If it's that the colon's not working, I can help them. I can take out the whole colon and then hook the small intestine, remember that was going into the beginning of the colon, to the rectum there. I hook them together, and now the colon that wasn't working is not there anymore. The food gets processed through the small intestine, goes into the rectum, and they can go to the bathroom. These people feel a lot better. So, I want you to feel good about the fact that most people respond to simple measures when they're constipated. They don't go through all that workup. But a few are going to need surgery, and if you work them up well, you're going to take the colon out and they're going to feel better. My challenge again, the students in the audience, we haven't figured out a good drug for colonic inertia. Maybe they could just take a pill and kickstart the colon so that it's working, so I don't have to do a big operation on them? Or can you make a pacemaker for the colon? What if we could put some electrodes somewhere and zap them and make the colon function? Okay? Thinking out of the box. You can do it. I mean, does it get better than this? I don't mean to kind of put them between constipation and anal fistula. That's kind of our little secret here, okay? But now we're going to talk about another benign condition that's really interesting but hard to understand. And my colleagues said I was kind of crazy for teaching this to you, but I'm up for the challenge. So a fistula is a connection between two parts of the body that doesn't belong. And I want you to think of it kind of as a tunnel. This is a tunnel. So we're looking first at the very low part of the colon, the rectum, and the anus, right to the outside. And there's a little hole inside the rectum, and it's coming to the outside skin of the buttock, to the cheek. Okay? That's what we're going to be talking about. Well, look at this. Hippocrates talked about this. 430 BC. They were talking about fistulas. And he started talking about a treatment. And we still use that today. It's called a seton, and it comes from the Latin seta for bristle. More about this as we move on. Poor Louis XIV was plagued by an anal fistula. He had a lot of trouble with this. He smelled really badly because he kept leaking this stuff out of his bottom. And someone ingenious came up with a way to treat it. And it's kind of remarkable. It's like a probe here, and then it goes into a little knife blade there. So he put the probe in, and then as he inserted the probe and moved it through, he could cut through the fistula. And apparently this instrument is available in the Palace of Versailles. You can see it. There's a hospital in London, not related to Louis XIV, but it's called the St. Mark's Hospital. And this hospital was created to treat patients with anal fistulas and other anal rectal disease many, many years ago. It's in the 1800s. Okay, now there's not going to be a test on this, but again, I want you to understand that there are different kinds of fistulas. And again, it's a tunnel from the inside to the outside. And the thing that gets complicated and confusing about this is that some of the fistulas are superficial. They don't involve the sphincter muscle that allows you to hold things in. And some of them cross it and go through the sphincter muscle, and hence where all the problems start. So, how do we treat this? There are some simple ways. If the fistula is superficial, like I said, not going around muscle, you can do an operation where you just kind of open up this tunnel. You unroof it, clean it out, and you're done with it. You've opened this up. That's all you have to do. The body heals it in somehow. It's miraculous how the body heals things in down there. It's dark, it's dirty. Every day something comes through and rubs against it and takes the scab off. Somehow the body heals it. I don't know how. Now we're back to that seton from Hippocrates. You can put a loop around that fistula tract going from the outside to the inside hole and loop it around. Fistulas come from an infection. The infection starts in these glands in the anal canal that everyone has. They tunnel their way out and form an abscess, a collection of infection, and then this bursts to the outside. What we do with these setons, these special drains, is sometimes we put a drain in just to drain the area, and sometimes we're going to tighten it up. So you can see here, again, I'm not trying to confuse you, but there's a way to put like a little string or thread there, tighten it up around the muscle, and then what happens is it slowly cuts through the muscle. So instead, if I just did that fistulotomy, like I said, the first case, it would spring it apart. And if I'm going through muscle, the patient would lose control. That's not good. But if you put the string around it and it slowly cuts through the muscle, it's cutting through muscle fibers slowly, like this. And then, but behind this, you're forming scar tissue. Scar tissue forms and fills in that area, so the muscle doesn't spring apart. This is a very nice, conservative way of taking care of potentially a big problem. Now, there have to be other ways to treat this, right? Why don't we just put in some crazy glue? I'm sure people have tried that. It's not, don't recommend it, it's not FDA approved. But you can use the body's natural glue, fibrin, and you can actually squirt it in and hope it works. Hope, because it doesn't usually work, unfortunately. If you guys can come up with a better way to do this, that would be great. So someone thought about it. They made a plug. Makes sense. Just plug it up. Put a cork in it. Stop it. So this is some special stuff made of actually pig intestine, and it helps you create, through a collagen scaffold, the body can then fill in with its cells and seal up this tunnel. A couple of people in the country say this works well. They're working on newer products. In most of our hands, it doesn't work. So then there's a procedure called a lift procedure. This is the latest procedure that we're currently doing. And basically, you don't have to learn exactly what I'm doing here, but basically, you have your tunnel, you're dividing the tunnel and tying off both ends. And what that does is, it allows you not to keep seeding the tunnel with stool and bacteria so that it seals off and heals. This is promising. So now why am I showing you taxis in Rome? There I am, lucky enough to be at an international meeting in Rome, and I'm sitting in a taxi cab with Dr. Abkarian, who's an American colorectal surgeon, one of the gods of American colorectal surgery, and his specialty is fistulas. So I was so excited. Here I have this expert with me, and I can ask him about the lift procedure. And I say, so tell me, Dr. Abkarian, what do you think about this lift procedure? He says, I hate it. I was crushed. You hate it. I'm like going to start doing this procedure. It's the answer to all our problems. I said, why do you hate it? He says, I hate the procedure because I wasn't smart enough to think of it. Okay, so here we are. Fistulas. Pig intestine, Miss Piggy. Lift procedure. You guys can come up with something new. Think about this. We've been trying to treat this since Hippocrates, and we haven't quite figured it out. And this is an area where if I do the wrong thing, I am at significant risk for being sued. And in some sense, rightfully so, although I may have done the right thing, but if all of a sudden someone is having accidents and can't get to the bathroom in time, that's a big problem. And believe it or not, if you sat in front of a jury and you showed them my whole CV, and then you showed them the underwear of someone who can't get to the bathroom in time, guess what? All those things I did just doesn't matter. You might as well settle before you go to court. So a Nobel laureate, the first American Nobel laureate in literature, said something like, the past is the present is the future too. So I'm hoping that we can change that thought process in fistula surgery and not still be using cetons soon. Okay, finally, Lakshmi, we're going to get to colon cancer. And just some random thoughts about it. This is not going to be a full course in it. But we'll talk about some basics and some different presentations. We're going to talk about blockages of the colon, not constipation, but a real blockage, and laparoscopy, robotics, how you put it together, and a little bit about cancer research in rectal cancer. So as we heard, it's Colon Cancer Awareness Month, and this is the Colon Cancer Alliance. And just some facts: second leading cause of cancer-related death in the United States. On average, your risk is about 1 in 20. 90% of new cases occur in 50 or older. We were talking about this with the students. If you have a first-degree relative, though, your risk goes up. And there are currently more than 1 million colon cancer survivors in the United States. We should mention a little bit about the polyp cancer sequence. You know, how does a colon cancer develop? It starts with just normal lining and progresses slowly, growing to a cancer. And you can see here normal cells of the lining, and then the crypt somehow starts changing, and you get abnormal growth here into this polyp, and then eventually to cancer. And then if you look here, we're starting to learn a lot about the different genes that affect each step of the process, going from normal to abnormal lining to the actual polyp itself, and from the polyp to the cancer. And some of the genes are listed here. This is stuff that you guys can work on. There's a lot more to this. So now let's talk about different kinds of colon cancer. Whoa. We're getting some bugs in here. We're going to talk first about a right-sided colon cancer. They don't present as a blockage. Now let's think about why. The contents of the intestine coming into the colon from the small intestine is liquid. So if you have a tumor on this right side, it would have to be huge to block a liquid from going through it. So these patients present with anemia, a low blood count. Why? Because this tumor is growing, and every day it's leaking a few drops of blood, a few drops of blood. And over years, you become then anemic. I think I'm, okay, good. Left-sided colon cancer here is going to present with a narrowed stool. Someone comes to me and says, doc, I have ribbon-like stool. That's a red flag to me. That's not a good thing most of the time. Or if they're saying they're bleeding, most of the time bleeding is going to be from something benign like hemorrhoids, so don't freak out, you don't have colon cancer. But you could, especially as you're older, if you're having bleeding, especially not bright red bleeding, could be bleeding from the tumor and is close enough to the outside that you're going to see the blood. So this is a complete blockage. There's just a very small opening there. So you can imagine, by the time the water is taken out of the colon, out of the stool by the colon as it gets to that left side, it's not going to get through that little hole. So you could, if you have a complete blockage, you could give someone a colostomy, hopefully temporary. Upstream from the blockage, you relieve it by bringing out the colon to the skin surface. That would relieve it, but not that great if you don't have to do it. So then there's something neat. It's called a stent, a colonic stent. People have heart stents in their coronary arteries to open up the blockage there. Well, now they've made them for the colon. And you can put this in with the colonoscope. You get up to the blockage. You take a little wire. You put it through the blockage right there. And then you place this stent in that expands. Now, it's made of nitinol, which is a nickel-titanium combination. It's heat-sensitive, crystalline structure. This is how it works, and you guys can explain it to me, because I don't really understand it. But you're going to know that in certain things that you do, you're not going to always understand exactly how it works. But for me, it works well, so that's good. And this is the stent. You can see it closed and how it goes through opening. And this is now the opening through which the stool now can pass. So you've taken someone with a blockage, can't poop at all, not going to poop through that narrowed lumen with the tumor, and now they can. So you can either start your treatment, maybe they need chemotherapy first before you operate on them, or you can at least make the colon less dilated so when you go in it's not as hard an operation. Can you make a better one for us? Maybe one that doesn't clog? Maybe one that's easier to retrieve if you have to take it out? Maybe one that stays in place better because sometimes they migrate, they come out. Maybe one that delivers a treatment and takes care of colon cancer right there. Maybe one that continues expanding a little bit more so that it doesn't just open to one size and can get a little bit bigger. How about operating on people? We used to make a big cut. I'm going to show you that in a second. But now we're using laparoscopy, which is a smaller cut, and these little devices, trocars, that we can then put a camera through and working ports, and we're looking here on the screen. We're not looking actually into the belly, we're looking through this camera. And here you see a diagram of the ports in here, and this is an actual picture, the colon, and we're cutting the colon away from its attachments to the abdominal wall. That's how we do a lot of our surgery now. Old scar, big scar up and down the belly, small scar, little stab wounds here. This is how we do it now. So smaller incision, less pain, shorter hospital stay, probably less traumatic to the intestine too. And importantly, it has the same outcomes, because you don't want to just do something for a smaller scar. So we had to prove with rigorous studies that the outcomes were the same, meaning the patients survived their cancer just as well with either technique. Unfortunately, what's happened though is that the public is sold on technique as opposed to maybe outcomes and technician. So everyone comes to me, are you going to do it laparoscopically? You're going to do it laparoscopically? I'm going to say, I'm going to try to do it laparoscopically, but during the surgery, I'm going to make a decision what's the safest, best operation for you that I can do. So if it means having a bigger cut, and that's the best thing for you, that's what I'm going to do. And some people don't like hearing that. But I'm not going to spend an extra 3 hours just to prove that I can do it laparoscopically if I think I can make a bigger cut and get this out in an hour. And that's just my philosophy. Robotics, the latest thing. We're not sure if this is the future for colorectal surgery, but it has some applications. So here's the patient, here's your assistant, here's the robot with all of these arms working. Here's the monitor so that the other staff can see what's going on. And look at this, the surgeon's sitting here near the patient, not right at the patient, operating. And what does it look like that they're doing? So here's the control panel, including foot control devices. And this is actually what we're putting our fingers in, these little graspers, and combining our hands and our feet. And you can see now this is looking up at the surgeon working, and you put your head in through a screen and you're watching what you're doing. So this may be the future. We're not sure. This is kind of looking deep down into the pelvis, going this way, looking down this way into the patient. And sometimes when you get down to very narrow areas that are hard to see or feel, the robot is helpful. And this may be the future for us, I'm not sure. It may be easier than laparoscopy in some cases, it may be harder. But just want you to know that the new robot costs $1.8 million. So that's a lot. So that has to go into how you figure out if you're going to do it or not. How do you put the colon back together again? You can sew it back together, that's one way. And it was kind of neat. I went back and looked at some of the original work on this over 100 years ago. And it was fascinating. Things we take for granted, they spent hours and pages of what kind of suture material, how deep do you put the suture, How tight do you tie it together? It was fascinating. We just put it in and tie it. That's it. But they had to struggle through that learning process. Now we also staple together. There are different kinds of ways of stapling. This is called a linear stapler. It goes in a line. Then we take advantage of working from the rectum as well. You can use a circular stapler, and part of the instrument goes in through the bottom, and then we mate it with the colon from above. You see here, the colon from above, and we mate those two together and do a circular anastomosis. These are titanium staples. So here, it's that simple. You can figure that out, right? It's a B configuration. That's what we want in the original staple. The newer one is this three-dimensional B that we think is a little bit better. It's a little more hemostatic. The original staples were actually invented by the Russians, the circular stapler, and then brought over to the United States and improved here. They had to load each staple into the stapler originally. It was pretty awesome. So the future, maybe you can come up with a way to have precise tension. It's not precise how we put it together. Maybe there's a way to figure that out. How about the blood supply? Sometimes we're wondering, is there enough blood supply there? Because we have to free this part of the colon up to hook it together. So there's a way to do this now. You have to buy the instrument, but you inject cyanin green into the patient, and then use a special monitor to see that there is enough blood supply here. Maybe you can invent a way to have a little electrode right at our anastomosis, right at the hookup, that will send back constant signals and information telling us it's healthy, it's good, the blood supply is still good, or it's starting to leak some stuff. Maybe the pH has changed. Maybe the oxygen tension has changed. Something that would tell us what's going on there. Plenty to think about. So this is a New Yorker commercial. It says, it's always sit, stay, heal. Never think, and innovate, or be yourself. I love that. That's great. Now a little bit about rectal cancer research, and then I think I'm finished. So for rectal cancer, it's a little bit different than colon cancer. Most patients need to get treatment before. They need to get radiation and chemotherapy so that we can cure them as well as we can cure them of colon cancer. Why? Because in a bony pelvis, it's harder to get that whole thing out. You have the confines of the bones that make it harder for us to take it out. So we take advantage of chemotherapy and radiation to shrink it so that when we go in and take it out, it's easier and we still do a good operation. But we don't know ahead of time who's going to respond completely to that or not. Some people will, some people won't. If we could figure out a way of who beforehand is going to respond, then we save all those people that are not going to respond this extra treatment. So there's a way to figure this out on tumor biology, and a lot of people are working on this. We're doing a small study on this as well. And it has to do with taking the original biopsy through that colonoscope of the rectal cancer, taking that tissue, and then looking at it from its RNA and looking at a set of pre-selected cancer genes. And we're trying to see if we can identify the patients in the past that have responded to treatment and those that haven't. And is that pre-selected panel of genes going to give us the answer? So that's what we're working on right now. We're doing this little panel. Dr. Haber Gama in Brazil, she's a brilliant colorectal surgeon at the end of her career. They're looking at the whole genome of patients. They have more money than we do. Whoops. Eisenberg philosophy. Don't forget the past, but always look to the future. Force your teachers to make you think. If they're not doing that, that's your problem. It's theirs too, but it's really your problem. How do you make them force you to think? Ask them good questions. Study the night before, know what you're going to be talking about, and then ask them good questions. And they'll start paying attention because they want to know the answers to your questions. Live outside the box. I've been told that I live outside the box, and that's just fine with me. Then I love the motto from my school. I went to Brandeis. So it's truth even unto its innermost parts. I kind of like to live by that. It's hard to do, but think about it and try to live by that motto. And this is kind of a surgeon's motto. We expect perfection, but we accept excellence. That is a hard place to live every day. But if you think about it, if you're going to have an operation, you want me to be perfect. You want me to do a perfect job every time. I'll accept excellence, but nothing less. It's a lot of students were asking me about pressure. It's a lot of pressure. Those that take it seriously, that's where we live. So I thought we'd quote Einstein to finish. We cannot solve problems by using the same kind of thinking we used when we created them. So, this is a serious Einstein, this is a happy Einstein, and Miley Cyrus, eat your heart out because he did it before you. Thank you.